Hi, I'm Jack Cush. We're here at RWCS 2019 in Maui. Great meeting. Even better are the posters brought here by the fellows. I'm here with Mike Putman. He's a fellow at?
I'm at Northwestern in Chicago.
Excellent. What year is last year?
I'm a second year, but I'm staying on for a third research year, so I'll be around a little longer.
Superb. Mike is the host of the Evidence-Based Rheumatology podcast. Check it out on iTunes or on wherever you get podcasts. I listen to him. It's great. Mike, tell us about this poster. I think it's kind of interesting. You sort of attempted to look at controlled trials in the rheumatology literature. What was the purpose? What was your objective?
Yeah, so I had a couple things I was curious about. One was, over time, has the quality of trials changed? And then a couple other things related to whether industry funding or not industry funding affects the quality of trials, and how big the effect sizes in the rheumatologic literature were. And so I kind of assessed a couple of different questions.
So what was your choice? What trials were you going to go to? Obviously, you could choose millions, and that's just in rheumatology.
Yeah.
So what did you hone down to?
So I decided to narrow in on randomized controlled trials that specifically assessed a pharmacological intervention against a comparator, whether that's placebo or an active comparator, such as another medication.
And are these rheumatology trials?
Yeah, so I looked at the top 3 rheumatologic journals, the Annals, Rheumatology, and Arthritis and Rheumatology. And then I looked at 1998, 2008, and 2018. And I just read every single randomized controlled trial in those years.
So different diseases, different drugs?
Yep, all sorts of diseases and all sorts of drugs.
So why did you do a cross-section like that as opposed to, let's just say, focusing on PSA trials or RA trials?
Yeah, good question. I thought about doing just RA and doing more years, but I felt like getting a broad swath of the rheumatologic literature would kind of let me be more generalizable.
Okay, that's interesting.
Yeah.
So what was your takeaway? What did you find, or did you find anything that's surprising?
Yeah, so we found, we looked over, ultimately 85 trials wound up making the cut. Over time, not a lot changed. There was a small increase that was statistically significant in sensitivity analysis and intention to treat, but an overall quality scale did not show any differences. Industry funding was interesting. Industry trials tended to be better. They're more likely to use blinding, they're more likely to use patient-reported outcome measures, and they're more likely to use an intention to treat analysis, and on a quality scale, they were more likely to be better. And so I found those are the main differences between those two variables.
And that makes sense because their objectives are to get their drugs FDA approved, and the FDA rules and guidelines on doing the right trial are pretty standard, pretty well known, and other people that do trials don't necessarily have to hold themselves up to that standard. So interesting.
Yeah, I think it's an incentives thing where the incentive for industry is to run good trials so that they can get the FDA to approve the drug.
Absolutely.
The incentive does cut in a way that I think is a little bit less optimistic. So in 1998, almost half of our trials included an active comparator, so methotrexate against a TNF. By 2018, it was only 1 in 10. And so a lot of what we're doing these days is comparing an active drug against placebo as opposed to a drug against another drug. And I think we're losing out by not doing those kinds of trials because there's a lot of times when you want to know what should you give for myositis, and we don't know.
And I'll give you my perspective on this as someone too old, in that the reason that was going on compared to today, the drugs in 2008 and 2018 are newer drugs, and there's a lot of new drugs being developed, and hence the objective is just get it to market, get it FDA approved, and there you only do placebo-controlled trials. In 1998, that's when infliximab and etanercept started, and Areva was started at that time. But up until then, there wasn't a lot of drugs. So if there were studies happening, it was 1998. These would have been studies that were done before 1998.
Yeah.
People are looking for the answers for the currently marketed drugs, and so you're more likely to see these head-to-head comparisons. So in the life cycle of a drug, you start out with a lot of placebo-controlled trials, and then maybe over time you get into more comparator trials. But I agree with you. I think comparator trials are what people are asking for now, because sometimes you're faced with A, B, or C decision, and the placebo is not one of those choices.
Yeah,
right?
It's usually not a good option.
Right. So,
yeah, I think optimistically a lot of this is us being a victim of our own success, which is a positive finding.
It's a good problem to have, right?
It is.
I'm always confused by funnel plots. Tell us what that was about.
This is a fun one. Let me walk you through it.
Yeah.
So on this axis is the precision of the trial. I use the number of participants in the study as a surrogate for that. So around here is about 500 participants, and around here is 0. And then some trials report absolute risk reduction, so that's the blue dots, and then some report percent improvement, that's the green dots, and I overlaid those on each other so the scale is the same. And so a trial here has 5 participants and a 50% absolute risk improvement. So what you see from this chart, which I think is relatively striking, is that small trials have a much larger percent improvement or absolute risk improvement. And so you see a large effect size with smaller studies. And as your N goes up, and hence the precision of the trial improves, you see a smaller and smaller effect trial. So it's kind of a reminder to not trust small trials. And the second thing is that there's a total lack of negative trials.
That's the reporting bias.
Yeah,
right?
I think there's two takes that are both reasonable. The first is that there's an incredible amount of reporting bias, and that we're just publishing positive trials, and that all these negative ones either don't happen, or they get censored somehow, or the journals aren't interested. A more optimistic take is that by the time you get to a randomized controlled trial, you're probably testing a therapy that you think works if you're going to spend all that money. And so the pre-test probability of success is actually a little bit higher. And so if that's true, then we would expect, this to be the center of the funnel plot as opposed to zero.
Right.
And so maybe this little mound here is what's happening. It depends on how you squint at it.
And what about those crazy outliers out there? Are those the most successful trials in rheumatology?
Yeah, like this one right here was phenomenal.
Yeah.
There's a couple with large effect sizes that were large, and yeah, I mean every once in a while you do hit a home run that in a large randomized controlled trial you see this is a 50% improvement.
All right. So having studied this over 98, 2008, 2018, what's your advice to pharma when they're making up their next 3 trials for the next 3 years?
That's a good question. And this kind of goes back to what I was saying about incentives. I think pharma is responding to incentives that are appropriately driving the creation of good trials. I think the onus is on us as clinicians to try to fill the gaps that these incentives aren't driving. So I think that doctors need to be running these comparative effectiveness trials to see whether we should be using Imuran or Cellcept for myositis and things like that. I think that would be a good direction to go. I mean, 84% of RCTs are funded by pharma, and so trying to find more creative ways or cheaper ways to fund trials ourselves, I think, is actually my take-home solution.
All right, Mike, great poster, the Evidence-Based Rheumatology Podcast. Check it out. More good posters, more good videos from RWCS.
Thanks so much.